Good afternoon, and thank you for joining us. I'd like to start by expressing our appreciation and gratitude to the AUA for the opportunity to share this webinar with you today. My name is Encore Stein. I'm the Senior Director of Marketing at Calyxo, and I'm pleased to host this session. We'll be reviewing recent data on the second-generation CVAC system and its role in improving stone clearance through aspiration, and including findings that were just recently shared at both EAU and AUA. It's a privilege to welcome our distinguished faculty, Dr. Seth Bechis from UC San Diego and Dr. Jared Winoker from Northwell Health. They'll provide their insights on the data and their experience with the CVAC system and its place in kidney stone care. We're grateful that you've all joined us today and hope you find this session valuable. Today's webinar will begin with a discussion on the evolution of technological innovation in retrograde intrarenal surgery. We'll review the differences between suction and aspiration technologies that are currently available in the U.S. And highlight how these approaches vary. We'll then shift to newly presented clinical evidence on the CVAC system, including real-world data, ex vivo and in vivo findings on intrarenal pressure, and then comparisons of the CVAC system with flexible and navigable sheets, as well as direct in-scope suction. There is a Q&A function at the bottom of your screen. Please type in questions during the course of the webinar, and we'll address them at the end of the session. And with that, I'm pleased to turn the presentation over to our faculty presenters, Drs. Jared Winoker and Seth Bechis.
Thank you for the introduction, Encore, and thank you to the AUA for putting this together so we can speak about our experience with the device. My name is Jared Winoker. I'm an endourologist, and I'm the director of the Center for Kidney Stone Disease at Lenox Hill Hospital in New York City, which is part of Northwell Health. I've been using the CVAC system since 2021, dating back to the first iterations of Generation 1, and looking forward to sharing my experience with you today. These are my disclosures.
And I'm Seth Bechis. I'm an endourologist at UC San Diego Health. I perform a large volume of stone surgeries here, and I've been using the CVAC system since June 2023. I look forward to sharing that experience with you today. Thanks for having me. And these are my disclosures.
Great, so I'll kick us off. So obviously, we're talking about the CVAC device today, but to kind of take a step back from all of that, we kind of want to discuss what is suction and aspiration and why is it so important. We know it's important. Look at 85 abstracts just at this year's AUA, and I think you can appreciate if you follow the literature that really in the last 2 years, we've seen this boom in suction-based technologies that are really aiming to improve the effectiveness and efficiency with which we perform retrograde or intrarenal surgeries. So the technological advancements we've seen in endourology and stone disease have really accelerated in really the last decade, with many of those advances being smaller scopes, smaller chips that improve visualization, higher powered lasers that have emboldened us to tackle larger stones. But anyone who's ever performed a ureteroscopy knows that residual stones are a major issue, and perhaps for a very long time we were overestimating how good we were doing with that procedure. Really, the seminal first publication on this was from Dr. Pearl at UT Southwestern, where she looked at her own patient experience. And anyone who's ever worked or trained with her knows that she is a very thorough surgeon and an aggressive basketer to make sure she gets every last piece. And even with that being performed on post-operative CT scans, only 50% of patients were stone-free. And that has since been multiple times over corroborated by multiple large institutions, institutional experiences, that is. And that includes the EDGE consortium we see here. And they took that evaluation a little bit further to really understand what is the true impact of these stone fragments. And we see that all residual fragments are clinically significant, whether they're causing future obstruction, stone growth, unplanned ER visits, and other complications. And then if we also think in terms of what do our patients want, an internal survey showed that 80% of patients want an effective, efficient treatment that's going to clear all their stones in one treatment and get it right the first time. The remaining 20% are likely those patients who just don't want to have a surgery at all. So when we talk about aspiration and suction, certainly these terms are sometimes interchangeable, but we really are trying to emphasize that there is a distinction between them. When we're referring to aspiration, we're referring to an efficient removal of the stones with a suction-based technology, and that right now the only system on the market for that is the CVAC system, which we'll be discussing today. And that's in contrast to our suction-based technologies, which are existing technologies in the stone space that have merely added a suction-based element to an already existing product, as opposed to developing a device around stone aspiration. So a flexible and navigable sheath, also known in the community as fans, and then DIS, standing for direct in-scope suction. And we'll talk a little bit about how these things work, especially when we look at some of the comparative studies later in this presentation.
And so if we look back on the development of the technology, the first generation CVAC aspiration system shown here was the world's first steerable vacuum aspiration system. And the idea behind it is not only did it provide aspiration to this large lumen, but it was navigable. So you could direct it into different calyces regions in the kidney under fluoroscopic guidance as shown here, and use that to treat the stone in any location based on where you had been treating it previously. It was widely used during its initial debut and was very successful. We could go back one. Oh, this is it. Yeah. So then there's the evolution of the device. And so now there's the contemporary CVAC 2.0, as we call it, which married a ureteroscope to this device. So not only do you have the aspiration and the irrigation, but you have direct visualization. And I would say this, compared to other suction devices that are currently on the market, this device has a unique design because it has three things. It has the microjet irrigation, which you can see here in this video on the right. The microjet irrigation has the fluid that's coming out around the circumference of the device for irrigation, which causes a simultaneous flow, and you have aspiration that's happening real time through the inner lumen. Even if you're treating with a laser at the time, treating the stone, you do have simultaneous flow back. And finally, you have the large outflow lumen as well. And so I think these three things really combine to make it a unique device and successful in what it does. If we look at the early feasibility data in the study by Dr. Sir's group, looking at the SURE procedure, they essentially achieved a 100% stone free rate at 30 days on CT scan, compared to only 75% stone free rate for conventional ureteroscopy using basket extraction. And so I think this highlights that with this aspiration and the continuous flow, you're able to significantly remove significantly more stone volume versus basketing alone. What's really, I think, exciting about this technology is not only can you treat a traditional, what we might think of a traditional ureteroscopic stone target, which would be any stone anywhere from several millimeters up to 1 or 1.5 centimeters, but they also looked at this technology for larger stones, anywhere between 2 and 3 centimeters and even greater than that. And you can see in this study that the CVAC system drastically reduced stone volume regardless of the baseline stone burden. And so in this example here of 43 patients treated using CVAC, the average stone burden was 3 centimeters. And what's interesting is 21 of these patients were counseled that they would likely need a secondary procedure, in part due to the large burden of stone. But of those 21, 90% of them avoided needing a secondary procedure, which speaks to how effective this is at aspirating out all the residual fragments, or preventing residual fragments by aspirating all of them during the case.
So building on a lot of this, really encouraging, exciting, perspective and non-randomized data comes the Aspire trial. So this is really a pivotal study and really the only level 1 evidence we currently have in the space of suction-based technologies with regards to stone outcomes. So the Aspire trial was rigorously designed as a head-to-head RCT comparing standard or traditional ureteroscopy with or without basketing at the discretion of the surgeon versus CVAC device. And specifically, that's the CVAC Generation 1 device that Dr. Bechis described. Looking at stone-free outcomes and complications. And what the authors found was that the Shore procedure, that is with the CVAC device, it was statistically superior compared to a traditional ureteroscopy in achieving a mean stone clearance of 97%. And if you're to look at the figures on the right, what we can see is that as the baseline stone volume, and that's really what matters, we're talking stone volume, not just diameters, as the stone volume goes up, we really see a flat curve for the Shore procedure with CVAC, meaning that it's relatively agnostic to stone size while maintaining effective stone clearance regardless. However, as we've all experienced or can expect with traditional ureteroscopy, effective at very small stone volumes, but as the stone burden goes up, we see diminishing returns with regards to stone clearance. The authors then follow that up with the 1-year data. And here we're specifically looking at healthcare consumption events. And what we found is that the CVAC device was associated with significant lower events compared to traditional ureteroscopies. We're talking fewer emergency room visits, unplanned or unscheduled retreatments, hospitalizations. So really, we're not just looking at a better outcome for our individual patients, but really a positive impact on a health economic impact that is on a greater scale. And so building on some of this emerging data, we want to transition that to now what's available is the Generation 2 data. So a lot of research has come out that is really aimed to evaluate the efficacy and safety of the Generation 2 device.
And I think one thing as a background is it's important to recognize that there are different types of studies and levels of evidence that are in the literature in terms of how we study these different technologies. And I think these different considerations are important to keep in mind when it comes to analyzing data such as stone-free rates across technologies. Dr. Winoker mentioned the randomized controlled trial as being, one of the highest qualities of evidence. We also have real-world experience studies. We have head-to-head or comparative studies, safety and feasibility studies. But I think it's also important to recognize what are the outcomes and how are they being measured. So some of the data we've hinted at has looked at stone-free rates, and I think how that's measured, whether that's with a CT scan, which is, according to the Journal of Endourology and modern views, I think stone volume and CT scan definition of stone burden is emerging as a more useful marker. Also, what are the thickness of those CT scans in terms of slices? And are we looking at volume versus linear dimensions? So I think, when we look at these data, when we talk about stone clearance, you just have to keep that in mind. Are we talking about CT scan based data looking at stone volume, or are we looking at a KUB or an ultrasound? And also what, in terms of long-term outcomes, are we looking at ER visits and retreatments over 30 days versus a year? Things like that.
Yeah, I think that's a really great point to transition on, Dr. Bechis, because as we transition here to some of our real-world data with Generation 2, it's just that a lot of the implicit bias in real-world data comes down to how we are evaluating stone-free rates and therefore the effectiveness of treatments. So one of the larger experiences we've thus far evaluated with the Gen 2 device, this is from my institution at Northwell in New York, where we looked at over 200 patients who underwent Shore with the CVAC 2.0 over a 1-year period, of which 163 had complete preoperative and postoperative data. That's performed by 21 different surgeons of note. The majority of those surgeons were not self-defined endourologists or fellowship-trained endourologists. Many of the included cases by these various surgeons were, they contributed maybe anywhere from 1 to 5 cases, so relatively early on their learning curve. So we're really getting a good real-world experience of how this thing works outside of a controlled clinical trial. Important notes, especially for those looking to adopt this, less than a quarter of the patients were pre-stented. All of them used a 12-14 by varying length ureteral access sheath. And I believe all of our cases were post-operatively stented for at least a few days. Relatively efficient procedures with median operative time just over 1 hour, and very few of our surgeons utilized a stone retrieval basket, whether for fragment removal or for translocation of the stone. And I think that speaks to the ability to reach any location, even deep lower pole inferior calyces with the device. This is a distribution of these stones that were performed. Many of them, about 45%, falling in that 10 to 19 millimeter range, with about 17 to 18% in the varying groups you see there. And then if we can jump to the next slide. As far as post-operative outcomes, it's worth noting that because this is real-world data and the decision to obtain post-operative imaging was at the discretion of the surgeon, many patients did not, but still we had a cohort of several patients who did, and particularly focusing in on the 1/3 of patients who had a post-operative CT. And these stone-free outcomes you see here on the right are for patients who had either no stones in the darker blue, and the lighter blue is if you use a 2 millimeter cutoff. And what we can see is that the CT-based stone-free rates are certainly quite high for up to 1 centimeter, and they're also quite high in that 20 to 29 millimeter cutoff. There was a dip, but still quite effective in the 10 to 19, and we do see a drop off at 30 millimeters plus, many of these being some Herculean tasks by our surgeons trying to tackle staghorn stones, some up to 6.5 centimeters in total length. And I think it's just important to interpret these outcomes in the context of the real world generalizability, that because CVAC performs aspiration under direct vision, many times you are relying on intraoperative stone clearance, and therefore you don't feel the need to obtain postoperative imaging or post-op CT. So you're likely purging many of those patients who are truly stone-free looking at these rates. So I would say that as good as these numbers are, this probably underestimates how good the stone-free rate is, because certainly many people who were ordering CTs for their patients were likely expecting there to be residual fragments because they were likely planning for a second stage surgery. As far as the safety, this reflects a lot what we saw with Aspire for the Generation 1 device. Extremely safe. Less than 5% of cases had a complication within 30 days. 2 of those complications were severe complications with infectious requiring ICU admission. Of note, both of those patients were those sicker patients we know that did have a recent history of UTI, sepsis, plus or minus hospitalization within 30 days of the treatment.
And if we move on to some additional emerging studies, this is a study out of my institution reporting an early experience with CVAC 2.0, really looking at stone volume. And so we used a software program called QSAS, which is able to create a 3-dimensional reconstruction of the stone based on CT scan and calculate stone volume. And in this prospective study, to Dr. Winoker's point, we found that of the 74 patients, a proportion of them did not have postoperative CT scans, likely due to visual clearance during the case. However, in those patients for whom we did have a pre-op CT and a post-op CT, as shown in the figure on the right, you can see that the reduction in stone volume was greater than 99% for most patients. And this was based on a pre-procedure stone volume of around 600 cubic millimeters. So early data does show, significant reduction in stone volume kind of from a real world study perspective. And there's another study here by Cook work on this trend, looking at 42 patients across 2 hospitals and 14 urologists, showing a 96% stone clearance rate. So I think the data is emerging that in urologist hands in general, whether it's experienced hands at a stone center or whether it's in a real world experience, it's able to be successfully used. Also at our institution, we started looking at intrarenal pressure. So I think a hot topic in endourology now is intrarenal pressure and what role does that play, particularly in our concern for elevated intrarenal pressures, potentially putting a patient at increased risk for postoperative sepsis or infectious complications because of the concern for pilovenous backflow. And so I think the use of ureteral access sheaths and suction and aspiration devices is coming into focus as a way to help maintain a lower intrarenal pressure. And so in this prospective study at our institution, we compared the use of the CVAC system to standard ureteroscopy with ureteral access sheath. And essentially the take-home point is that there is no change in, there was no increase in intrarenal pressure when using the CVAC compared to standard ureteroscopy. And so I think this is really important because it shows that with that passive aspiration that's going with the device, you're able to maintain low intrarenal pressures. And this was against a variety of irrigation settings as well. Taking it one step further, Dr. Eisner's group did a porcine study. This is an ex vivo kidney model where a kidney and a ureter from a pig was used, and either the CVAC 2.0 or a standard ureteroscope was inserted with a ureteral access sheath up the ureter, and then the intrarenal pressures were monitored. What's interesting about this study is they modeled both a compliant UPJ and a non-compliant UPJ. So there are patients for whom the ureteropelvic junction, the proximal ureter, acts as a small valve that can be more or less compliant depending on the patient. And obviously a less compliant UPJ raises the risk for higher intrarenal pressures because it's not able to relax and vent pressures from irrigation. So in this model, they looked at both a compliant and a non-compliant system. We go to the next slide. And the take-home point is that the CVAC system maintained a low intrarenal pressure in both the compliant and the non-compliant model. What's interesting is in the pigs with the compliant UPJ, the intrarenal pressure compared to standard ureteroscopy remained low in both CVAC and your standard ureteroscopy. In the patients with a non-compliant UPJ, meaning a more stenotic or a tight proximal ureter, the CVAC system did maintain a lower intrarenal pressure. And so I think this is important, especially if you have a narrower ureter, or older patients sometimes have tight ureters or a narrow UPJ, or a patient with a possible partial UPJ obstruction. I think using the CVAC system potentially can help lower your intrarenal pressures during the case, which may translate into less postoperative pain or reduced risk of infectious complications. So that is interesting early ex vivo data, which I think will open the door to more studies in this area. And this is just a figure showing those tracings of the intrarenal pressure measurements. And so you can see here, they use the CVAC system with different levels of irrigation using a fluid management system, either 200 or 100 millimeters of mercury, with or without the laser bridge and the lumen in place. And you could see that even though there was variation in the intrarenal pressures, none of them exceeded the concerning level of 35 millimeters of mercury, where we think above which can lead to increased risk of pilovenous backflow and possibly sepsis.
Yes, thank you. So we've obviously taken a lot of look at the studies that have existed, both real-world experiences and in vitro and ex vivo studies on the genetic device. I think it's a good time to transition a little bit to how does the CVAC system stack up with at least what preliminary studies have been done comparing it to the other suction-based technologies that are out there. So the first study we'd like to highlight, this was done by the Mayo Arizona group, and this is comparing the CVAC 2.0 system to fans, so your flexible and navigable ureteral access sheath. We're looking at a non-randomized prospective study looking at 36 CVAC procedures compared to 87 fans procedures. It's worth noting that both technologies were overall highly effective in stone clearance, 99% and 96% for CVAC and fans respectively. But that does come with the caveat that the CVAC group had a significantly higher baseline stone volume. And at the same time, the absolute stone volume that was actually removed with the CVAC compared to fans was significantly higher, independent of that baseline stone volume. And I think really an important point is demonstrated here in these figures, where we're comparing the preoperative stone volume on the x-axis to the residual stone volume afterwards on on the y-axis. And what you can see in the first figure A is that with increasing pre-op stone volume, not only do you see a flat curve, you actually see a declining residual stone volume. So you're really looking at an effective treatment modality, regardless of your baseline stone volume. The fans, however, mirrors more what we've seen with traditional ureteroscopy, where as your baseline stone volume goes up, we're seeing a bump up in residual stone volumes. And then if we take a little closer look at some of the more granular data from this, we saw that procedure times were similar between the two procedures, even though the authors were able to obtain a 3 times larger stone burden with the CVAC procedure, which may give suggestion that it is a more efficient procedure, but that is not how the study was designed or powered to measure. And at the same time, if we're looking at complications, much like we've seen with much of the prior real-world data, CVAC is a very safe procedure with a low complication rate, which is also similar and comparable to that with the FANS procedure. And then if we look at an in vitro study done by Brett Johnson from UT Southwestern, we're comparing the CVAC procedure to aspiration with a disc scope, that is your direct insuction scope, where we're talking alternating inflow and then turning it off to do vacuum outflow. And just jumping to the video on the right, starting with the same amount of stone fragments, you can just see qualitatively how much more efficiently and faster that the CVAC device on the left is working compared to the disc procedure with a 3.6 French lumen. If we were to actually look at the quantitative data that comes with that, essentially what Dr. Johnson did was he looked at varying groups, 5 groups in total, of different median stone fragments, 1 to 4 being increased size stone fragments, and group 5 being a more composite of the prior 4. So that's a better reflection of real world ureteroscopy. And across all 5 of those groups, you can see on the figure on the far left, is that you have a significantly more efficient, that is a faster stone aspiration with the CVAC device compared to the disc scope. And that is regardless of stone fragment size. And many times in the disc scope, I believe the maximum of 2 minutes was set in this trial where they weren't even able to completely remove all of the stone fragments. So if we were to kind of put a bow on all the clinical evidence we summarized thus far, the CVAC device, that is, we're talking about the current second generation device, provides consistent outcomes which match what we saw in that more proof of concept generation 1 device, which was supported by level 1 evidence from the Aspire trial. We have proven real world experiences in large cohorts, both of patients and also varying surgeons of different experience, with high stone clearance and very few complications. We see that we have a more efficient and complete stone clearance, not only compared to traditional ureteroscopy, but at least in some of these preliminary studies, comparing other suction-based technologies like fans and discs. And because of that, many are, believe that we can certainly treat a wider range of patients, regardless of stone burden, as we do see that the treatment carries a little bit of an agnosticism to how well it can clear stones regardless of the baseline stone volume. And finally, we want to just highlight this is a very intentional and innovative design built around aspiration as the core function of the device, unlike other technologies where you're taking an existing device and adding suction to it. And that means we're translated to highly effective stone clearance in regards to low residual stones, and also safety, of course, maintaining low intrarenal pressures, which is paramount in any discussion about a ureteroscopic treatment or technology. So I think with that, we've kind of, gone through what's out there right now with the current literature. And I think it's a good point to transition to some real world experience where Dr. Bechis and I will highlight some of our case experiences. So the first one is one of my patients. It was a prohematuria workup for a 59-year-old man. You can see in the left renal pelvis, he has a 1.3 centimeter stone that is causing some degree of obstruction suggested by the hydronephrosis and, of course, symptomatic. And the patient desired, of course, a treatment, was not interested in a percutaneous, whether mini or standard perc, and obviously wanted a treatment that was going to be effective, highly effective the first time. So we offered him a CVAC procedure. So to take you a little bit through what we're doing in this video, I'm beginning with my lasering. I typically use a thulium to dust the stone, either 0.2 and 100, or I also prefer to use 0.5 and 30 is also an effective starting one. And we can see this is not the ideal case, not a cherry pick case here. It's a tough stone that's not necessarily responding perfectly well, but we're being patient. I'm paying attention to my vision. You can see the flow of fragments from right to left towards the central lumen of the device to make sure that I have good vision, good outflow, safe low pressures. Periodically, I'm going to actuate my laser bridge every minute or two, regardless of what my vision looks like, just to kind of stay ahead of any potential building up stone fragments or debris along my laser bridge that could down the line lead to a higher degree of obstruction of my device. I will intermittently pull back the device, as many do, into the renal pelvis, and we'll perform a renal pelvis pump. That's 5 1-second on and off pumps of it, just to flush everything through the entire column of the device and the internal funnel and aspirations. And I do that anytime I'm concerned that things aren't flowing, or really in any transition from one calyx to another. I'm going through the pelvis, I will perform that. And then when I feel I've effectively gotten my stone fragments as small as possible, I'm going to take out the laser bridge and I'll start to perform a combination of passive and active aspiration. And here you can see me demonstrably explaining to my resident where I'm staying away from the fragments that accumulated. I don't want to get into that sand pile and hit a big fragment that I may have missed. And I'm just letting the fluidization from those microjets kind of bounce off the walls and come to my suction, my suction channel. And then when I cleared most of that stuff and I can see what's there, I can purposefully go after specific fragments with the full trigger active aspiration. And in this case, there was an additional small lower pole stone fragment, whether it broke off from the stone or it was there. And it was in one of these tough corners where it's kind of pinned between the wall of the calyx and the papilla, kind of in that fornix area. We all know that one's very tough. The beauty of the device is that it's able to reach all the calyces. The outward flow of those irrigation jets can actually be used to your benefit to kind of flush it off the wall, such that you can laser it and actually suction it out or aspirate it out, as I did. And at the end of the case, taking you through here, very good vision, complete intraoperative stone clearance. By my assessment, I don't even see any dust or hint of anything. And I think this is a reason why many surgeons are not obtaining post-op imaging, regardless of what guidelines may say, particularly CT scans, because they feel pretty confident that they got a complete stone clearance. Ultimately, efficient procedure, only 36 minutes for a 1.3 centimeter stone. Patient did have a CT scan at about 2 weeks post-operatively for another indication. But at that time, the non-contrast phase clearly shows a CT-based, completely stone-free.
So this is a case of mine. This was a 90-year-old woman that first actually presented with an obstructing ureteral stone that brought her into the hospital with sepsis and a urinary tract infection. And she underwent ureteral stent placement. And during that presentation, she was found to have almost 2.5 centimeters of lower pole and renal pelvis stones in her kidney. Given her age and her goals of care, she did not want to undergo a PCNL, and she also did not want to have a stent for the long term. So after we treated her infection, we then brought her back to treat the ureteral stone, which we removed with a semi-rigid ureteroscope, and then also to treat these stones in the left kidney, because her goal was to not ever have to endure another episode of ureteral stent colic or stone colic. So we wanted to treat these in a minimally invasive way. And so we had already treated the ureteral stone. We were able to basket extract that. And so now this video shows the treatment of the renal and the lower pole stone. And I think one thing to highlight is with CVAC, you have that concurrent passive aspiration. So just like Dr. Winoker was showing, I try to dust these stones whenever possible. And so if the stone is amenable like this, where it's kicking off dust, you can sort of always monitor that continuous aspiration because you see the particles moving from right to left towards that 9 o'clock position. And your visualization stays relatively clear during that process. In this case, the stone was soft on the outside with a harder core, and so we switched to popcorning. And so at this, I use a higher setting like 0.6 and 20 or 0.6 joules and 30 hertz at a popcorn setting, and really just want to take that time to make those stone fragments become less than 2 millimeters. And then this is my favorite part. When you pull out the laser, you can see we activate the full pull aspiration, and you can see all those fragments coming out. So I think the key is, and then also like Dr. Winoker said, I do these alternating sessions where I'll do a half pull to sort of irrigate and flush out the fragments, and then a full pull to activate the aspiration. And I think taking that extra time to either dust or pop dust your stones so that they are less than 2 millimeter fragment sizes, it's worth the time up front, because then if you do it correctly and you don't have any stones hiding that are larger than that, when you do your aspiration, you're done. You don't have to put the laser back in. I think that's always a hard part, is having to put your laser fiber back in for those fragments that you uncover. And in this patient, she had a 6-week CT scan postoperatively and was completely stone free. So big win for her. I have to say this is one of the larger stones I had treated, and it went really well. Total ureteroscopic time was 42 minutes. And so how do we take all these insights and put them into our clinical practice? So we've presented some of the data today. We've shown you a couple clinical videos, examples from our cases we've performed. And I think the hope is to highlight that the CVAC system is effective. It can be used in a wide range of stone volumes in patients. And I think that's really important to highlight, is you can use this for a 1.2 centimeter renal pelvis stone. You can use this for a 2 centimeter stone. And it's effective with the aspiration. If you're able to treat the stone, it can aspirate the dust. We know that it's effective, and actually for larger stone burdens, it works equally well. And so this, I think, emerges as a competitor or an alternative for PCNL, and in a less invasive way. I think the data would show too that it removes more stone efficiently compared to standard ureteroscopy, and also for larger stones compared to fans as well. And I think we know that the better a job at stone removal you can do now translates into a better outcome for the patient. Less postoperative pain perhaps, but also less ER visits in general, less retreatment rates. So I think combining all these things makes it a really nice tool to have in our armamentarium for stone treatment.
And I'll just dovetail on a lot of those brief points that, in adopting any new technology, obviously safety is a very important metric. And whereas certain procedures require a certain degree of expertise, whether clinical experience or fellowship training, we see in a range of providers of different years of experience and some specialty expertise. It's very safe. And at the same time, of course, as Dr. Bechis mentioned, extremely effective. And that's not only in terms of intrarenal pressure and potential infectious complications, but also with regards just to the safety of the device intraoperatively. I don't think you've seen in any of those cases any bleeding, something that I've never really experienced because those pressures are kept so low. And so for those who are interested in trying, or maybe are planning to, or even early in the learning curve, I would just, as with any other technology, just stress some learning points that I had from learning this technology, which is to, pick those, what you would consider the more straightforward stone burdens that to really kind of get used to using the device and all the intricacies and how to manage and stay ahead of the fluid system, that you're not running into obstructions or other problems. And then thereafterwards, it's really up to you to kind of see where this fits in your practice with regards to, patient selection and stone burden.
Thank you, Dr. Bechis and Dr. Winoker. With that, we're going to open up the Q&A. Please use the Q&A feature at the bottom of your screen to type in any questions you may have. As we're waiting for some additional questions to come in, Dr. Winoker, you answered this to a certain degree, but maybe I'll ask Dr. Bechis as well for his perspective in terms of advice for those getting started on the CVAC system or any of these newer, suction aspiration technologies. What would you share based on your experience?
Yeah, I think that's a great point. And as with any new technology, as a surgeon incorporates it into their practice, I think it is important to note that there is a learning curve. Fortunately, the learning curve is not steep with this device, but I think there are tricks and techniques that are worth taking the time to familiarize yourself with. And so in terms of early patient selection, like Dr. Winoker mentioned, choosing easier, more straightforward cases like a 1.2 centimeter renal stone, just to get a feel for the technology, I think is always a good way to start. I think I've incorporated some techniques along the way that help make the cases go even faster and more efficiently. But just getting familiar with, I think, the balance of the irrigation and the passive aspiration, and then how do you use the manual trigger to take advantage of its full aspiration capability. And as you're dusting, if you have to do some fragmenting, I think taking that extra time to just really make sure all your stone fragments are small, less than 2 millimeters, before you remove your laser and switch over to the full aspiration. So taking that extra time up front to really treat the stone ultimately translates into a faster, more efficient case.
And if I could just add too, that I think some of the learning points, maybe not so much also for me, but just from other providers in my health system who I've spoken with, I think some of the where people ran into challenges were, first those who maybe a little cavalier and felt that they don't really need to have someone in their room, a clinical support specialist from the company to help kind of take them through things. Of course, taking on those bigger stones was a problem. And I think there's maybe some people who maybe dogmatically they take a different approach to treating stones, maybe the traditional fragmenters and basketers where, I think there's a little bit of those who are already dusters certainly understand that being as efficient upfront is going to save you time in the long run. The edge data kind of shows us that. But I really think that, whether you continue to fragment or maybe you transition into a dusting-based approach, like Dr. Bechis said, you really got to get small fragments. And I think being a little bit premature to remove that laser bridge and start trying to aspirate out fragments, one, can lead to obstructions, but also frustration with the device. So it's meant to be used effectively and properly, even though there is, of course, a range of technique and nuance that you can develop in performing the procedure.
And also just to dovetail on, especially when you're learning, having the support staff in your room. So whether that's the clinical experts, who are familiar with the scope and the technology, I think helping to educate the nursing staff in the room for setup, also just there to, help you monitor, is your aspiration working properly, make sure the laser bridge is correct. I think having those resources up front when you start for your first few cases is really important to get you on the right foot and highlight for you as the surgeon what you need to be paying attention to.
Absolutely.
And so how do you approach patient selection when it comes to these new technologies? Dr. Winoker, do you want to start with that one?
Yeah, this is going to be one of those do as I say, not as I do situations where admittedly I did tackle, a larger stone than I tend to recommend now. And thankfully it went well. But I think, it's almost like that stone size that you'd almost think is maybe a little too small to even do this. But what we know is that stone free rates are soberingly low, even for the 8-9 millimeter stones. So you're still giving this patient an effective treatment that's, potentially sparing them long-term complications from residual stones. So I think kind of tackling a bunch of those and stacking them up in a short period to kind of get over that early hump of the learning curve. And then you can start maybe expanding out from there.
Dr. Bechis?
Yeah, I think the same. It's funny, the more cases I've done, it's harder. It's harder to find a scenario where I don't want to offer the aspiration to a patient. You know, like what Dr. Winoker was saying, if you have even a 9 millimeter or 10 millimeter stone, we know that the residual stone-free rate, if you do a standard ureteroscopy, is high. And so if you have the opportunity to leave a patient with a lower stone-free rate or a higher stone-free rate, and reduce their risk of coming back or forming another stone in the future, I think it's worth offering. So I think with the advent of these technologies, I'm using more and more of them, and I think that's working out well for everyone.
So to that point, does standard ureteroscopy still have a role, and why?
It's a great question. I think, with the accessibility, I think obviously access to this technology, to these devices is not universal. So I think for healthcare systems, as they work on improving access to have these devices, that'll be important. I think cost is something that, still is important from the hospital perspective. How do you balance these costs, right? There's a cost to using this type of technology that may be more than a reusable ureteroscope, but I think we don't do a good job right now of understanding what is the total value add for a package. So even though you may have a greater upfront cost with using one of these devices, if it avoids a retreatment rate in 2 years or an ER presentation, there's a lot of additional cost savings down the road. So I think understanding that whole picture is something that there's opportunity to better understand as well.
I would say, of course, availability costs, critically important to even getting it in the door and available to a patient. But I don't think at the moment it has replaced it. And I say at the moment because we're not really sure exactly where this fits in the grand scheme of things, especially with the changes in technological advancements we're seeing coming so fast now. There are competing factors in retrograde stone surgery that are sometimes put at odds, when you're using things like an access sheath and a larger size device. And that's not to say you can't get away with that with this, but I think there's a push towards reducing stone-free rate in the field, but there's also an equally strong push, if not for a longer period of time, to getting patients stent-free after procedures. And those, it's perhaps a bit dogmatic, and I'm going to put this to Dr. Bechis because he actually had an interesting publication on this, but it's a bit dogmatic that, anyone who has an access sheath, for the longest time, we've been taught that, well, that's a patient that needs a stent post-operatively. And, that certainly doesn't seem like it's necessarily the case, but some people may feel that's a little bit at odds, and therefore that could be a reason for choosing a smaller caliber scope, despite, what you may be compromising in stone-free rate.
Yeah, absolutely. I think that's a great point. I think just, the AUA guidelines actually recommend that in select uncomplicated cases, even if you, after ureteroscopy, you do not need to leave a stent. That being said, 85-90% of urologists still traditionally leave stents after ureteroscopy. I think that's out of concern for possible pain, inflammation, infection concerns. And I think that paradigm is shifting. We've just been part of a study that found that even if you put in a ureteral access sheath in a well-selected patient, you can leave them stent-free, and they do fine. There's no increase in post-operative complication rates. That's data we presented at the AUA this year. So I think that paradigm is shifting, and I think especially if a patient is pre-stented, we're putting up a 12 French ureteral access sheath should not be a problem. But even in patients who have not been pre-stented, I think if you can, place a 12 French sheath for this device, or even not use a sheath at all and just place the CVAC device on its own, we're headed towards a world where we may not have to leave stents even in those cases.
That's
And
a,
if we're
that's
leaving
great.
probably behind. Yeah.
Yep, that's a great segue to the next question, which is, any tips that you can share to place an access sheath in an unstented patient?
So I traditionally, I always joke with our residents when I'm teaching, I try to do it the same way every time. So I typically will place a wire and then shoot a retrograde pyelogram to get a sense of the ureteral caliber. And sometimes you can appreciate if a ureter is particularly narrow or tight, you can appreciate that feedback. And I traditionally will try to use I do serial dilation. So I'll use a 10 French and then a 12 French inner obturator from the sheath. And if that goes smoothly, then I'll put in the 12-14 French ureteral access sheath.
Yeah, I mean, I have a similar approach. I don't do the retrograde pyelogram, but generally just in placing the wire in, and if we're going for the route of an access sheath, a dual lumen is going to be inserted, which is, at least the ones that many use is about 10 French. So you can already start to just get a little bit of that haptic feedback about the orifice or perhaps anything upstream about how easily it's going to go. And I do also do a serial dilation using the internal stylet first. And frankly, I use that internal stylet as kind of my tipping point about whether I think this is going to be a CVAC or if I'm going to do a traditional ureteroscopy, or if the discussion was preoperatively that it's CVAC or bust, then it's the stent and come back another day to place the access sheath for it. And there have been cases where I can get the internal stylet up, but I'm not able to get the full 14 French sheath up. And those have been the cases where I've more and more been dabbling with a sheathless procedure. But as far as, there's to the, the question being asked, unfortunately, there are people out there, different schools of thought that use balloons and things like this. I'm really very much in the camp of the anatomy's telling you, what it can handle. And I'd rather come back another day than, risk doing something a little too aggressive.
And I would say I've also shifted my practice. I now use a stiff wire to place my ureteral access sheath. And if I'm putting the inner obturator, which is 12 French in, if that goes relatively easily, but then I can't pass the full 12-14, that's the case where I may then place the CVAC up over the wire without a sheath. And that's because the 12 French inner obturator is very similar in size to the scope itself. And I've had success using the CVAC without a ureteral access sheath in those scenarios.
Yeah, I find the hydrophilic coating on the device to actually be a little more slippery than some of the access sheaths, frankly. And of course, I'm sure you do it also anytime I'm putting up without a sheath. That's including the included internal stylet over the wire to make sure that you have a tapering at the tip.
Well, thank you to everybody for joining today's webinar, and a special thank you to Dr. Bechis and Dr. Winoker for sharing both your insights on the recently published and presented clinical data, as well as your real-world procedural experience. Have a wonderful day, everybody, and we'll see you on the next one.